Welcome everybody to this talk on contracture and the implications of current evidence in relationship to prevention of contracture in humans. This topic has been profoundly challenging for my beliefs, and so in many ways this is a topic that gives an example of how evidence-based practice can influence each and every one of us in terms of our clinical decision making. The take-home messages from this talk are that we now have robust evidence that stretch interventions do not prevent contractures in humans. Serial casting, on the other hand, can lead to transient changes in range of motion, and that serial casting, when combined with other interventions, may be of benefit. And this has been shown to be the case in ankle dorsiflexion, however has yet to be demonstrated in upper limb outcomes. We all know that contractures can cause profound limitations to the opportunities of people to move, as we can see in these two examples. We can also measure range of motion, and in terms of force versus range of motion, in this example on the vertical axis, increasing force, on the horizontal axis, the range of motion. And here we see a curve of what we would normally expect to see in somebody that doesn't have a loss of range of motion. Somebody, however, with a contracture will likely have an increase in the stiffness of the tissue, that is, there's more force required to move the limb into range of motion, and there is an actual loss of range of motion that we can measure. And this is important in terms of our intervention decisions and whether we can demonstrate that there has been a change in range of motion. And many of the high quality studies have used measurements that actually do objectively measure the force and the range of motion. If we look at the incidence of contracture, in a study by Kim Kwa of 200 consecutive stroke survivors in a Sydney hospital, they were able to follow up 165 stroke survivors at 6 months, and they found that 52% of that population of people had a contracture at one or more joints, and that included the elbow, the wrist, and the ankle. In this study, they were interested in what the predictors would be as to why people developed contractures. They looked at the severity of the stroke, the muscle strength initially, and also the motor function, the coordination of muscles. And what she found interestingly was these factors only explained 1 to 17% of the variation in range of motion. So in other words, we still really don't know what the underlying causes of contractures are. I'm going to take a step back now to look at animal research, because this was one of the very influential pieces of scientific information that we used initially to make decisions about why we were using prolonged low-load stretches. There's clear evidence in animal studies that immobilization of muscles in shortened positions leads to very rapid changes in muscle. It causes contracture. There's an almost immediate loss of sarcomeres. In mice soleus muscles, for example, there's 40% of loss of sarcomeres within 2 weeks. It leads to atrophy of the muscles, and also changes in the connective tissue, and the muscles become stiff. So equally interesting though, that if the muscles are placed in lengthened positions, the opposite occurs. There's a growth of sarcomeres, the connective tissue doesn't become disorganized, and so there's a relationship between the resting position of the muscle and what actually happens in those muscles that is unrelated to any form of brain damage. It's purely a peripheral response to stretch. Animal researchers then went on to look at what happens if you then apply a stretch to a muscle that's otherwise in a shortened position. And Pamela Williams went on to investigate mice soleus muscles and found that if a muscle that was otherwise in a shortened position was stretched for only 30 minutes a day, that in fact that prevented those connective tissue changes from occurring. In other words, there was no loss of sarcomeres and no increase in stiffness in those muscles. The clinical implication of this information was that if we provided a stretch to muscles, this would prevent contractures from occurring prophylactically. And so interventions to the upper limb and the lower limb to try to prevent contractures was implemented. If we look at the resting position of stroke survivors' arms, it's commonly in internal rotation, elbow flexion, wrist flexion, finger flexion, thumb adduction. And these are common positions that we'll see people resting in after stroke. We can see here combined stretches for somebody for their lower limb and their upper limb. In this case, he's standing on a wedge to increase the ankle dorsiflexion, and the arm is in an air splint with the elbow in extension, the shoulder in external rotation, and the hand is around a jar to try to prevent thumb abduction contractures. In this other example, we have somebody standing on a tilt table on a 15-degree wedge with their arm once again in an air splint. And you can see on the table that they have a timer to be able to call out when their stretch is finished. And these were implemented on a routine basis for stroke survivors on a day-to-day basis. These stretching routines were implemented routinely, and it wasn't until the early 2000s that researchers started to objectively investigate whether in fact these interventions were of benefit to stroke survivors and people with spinal cord injury or traumatic brain injury. An important early study looking at the effectiveness of splinting was conducted by Natasha Lannon. In this trial, they were looking at the effectiveness of splinting in people post-acute stroke. It was a randomised controlled trial with 63 subjects, all within 8 weeks of their stroke. None of them had active wrist extension. It was a high-quality trial to minimise the bias of the researcher. And they compared 3 different conditions. The first condition was a resting splint, commonly made. The second was a wrist extension splint at the maximum the person would tolerate. And the third group was a control group who received no stretch. The splints were worn for 7 days a week, for 4 weeks, for up to 12 hours each night. The measurement is an important one to discuss using a controlled torque. So here it is, where a spring balance is used to measure the force that's applied at the beginning of the study, and that same force is applied at the end of the study by a measurement therapist who is blinded to which group the person was involved in, so they can reproduce the amount of force that was applied at the beginning of the research and compare that with the range of motion at the end of the research. And this is an important factor involved in maintaining the reliability of the measures in this research project. So what are the results of this study? The functional resting splint, there were no differences between the groups. And this is not unexpected, as the wrist wasn't placed in an extended position. The expectation was that the extension splint would actually provide the stretch, and perhaps this would demonstrate that a wrist extension splint would be of benefit. The results, however, are extremely surprising. There was no difference between the groups, with -1 degree the difference, and a confidence interval which crosses 0, so it means it's not statistically significant. So the conclusions of this study were that for stroke survivors with acute stroke and no active wrist extension, routine splinting for 1 month, 9 hours daily, did not reduce wrist contractures. Now, in some ways, we need to find ways to see this evidence if it doesn't fit with our current belief systems to be able to understand what it means. Here we have a way of representing the information graphically. So we have a clinically worthwhile difference that we can decide as clinicians that perhaps making a splint for somebody is worth perhaps 10 degrees because we need to make the splint, the time taken to make it, the materials, plus the discomfort for the person to actually wear the splint. Now, if we put in the results of this trial, we can see that in fact there was no difference between the groups for the wrist extension splint. I'm now going to go on and talk about some other trials and gradually add more results of trials to show you what the overall outcomes have been. Here is another trial looking at wrist and finger flexor stretch, randomized controlled trial with 40 subjects, mean of 29 days post-stroke, and once again no active wrist extension. This was once again a high quality trial to reduce the biases of the researchers to the trial interventions. The intervention was this stretch, which was applied for 1 month, 5 days a week, for half an hour a day each day. The control group received no stretch and they received usual care. The results were that in this study, those people that were in the stretch maintained their range of motion for that period of the month, but then in a week follow-up and then 1 month follow-up after the intervention, it was found that the groups started to come back together. So this is one trial that has shown that perhaps this particular stretch may be of benefit to individuals, but it wasn't statistically significant because the difference in range of motion that was required in this study was 10 degrees and not 5 degrees. So we can put the results of this trial into this tree plot and we can see that in fact once again the average difference was not statistically significant. Here is a trial looking at the effectiveness of serial casting on elbow flexors in a traumatic brain injury population. Randomized controlled trial with blinding of the assessors, once again a high quality trial of 8 out of 10 in the Pedro scale. 26 adults with traumatic brain injury with elbow flexion contractures. The intervention was serial casting compared to a control group that received no serial casting, but their usual 1 hour a day stretch. The cast was left on for 2 weeks, and then both groups, the control group and the serial casting group, were in a 1 hour a day stretch into extension of the elbow for 4 weeks afterwards. The primary measure, once again, was using a known force across the elbow to measure elbow extension before the intervention, 1 day later, and then 1 month later after the intervention. And what was found was really quite amazing differences between the groups immediately after the cast came off, with a reduction of the contracture by 22 degrees. However, 1 day later, the difference was only 11 degrees, and 4 weeks later, the difference between the group was 2 degrees. So serial casting seems to produce a transient change in range of motion, which is of benefit, but in the absence of other interventions, that range of motion is not maintained. So if we look at the results, here we see that the immediate difference between the groups is quite marked. However, 1 day later, both groups are coming back to the same position. So in the absence of other interventions, serial casting in and of itself may not maintain range of motion. So now we can start to add in other trials that have looked at both spinal cord injury, stroke survivors, and mixed spinal cord as well as mixed populations. And the results are all quite common in terms of their minimal difference between the groups after the intervention. The question is even more intriguing because it seems that it's difficult to induce contractures even when they're appropriate. In a spinal cord injury population of those that have quadriplegia, a tenodesis grip, particularly for those that have some wrist extension, is of physical benefit because they're then able to use that tenodesis grip to pick things up. In this randomized controlled trial, once again a high quality trial, 20 people with spinal cord injury from C4 to C7, up to 10 years post their spinal cord injury, they wore this splint for 3 months each night after. The splint was worn for a median of 77 nights. The results between the groups was 0 degrees. So in other words, it seems that even if the limb is applied and kept in this position, it doesn't induce a contracture either. So if we once again represent that outcome on our graph, that's what the outcome looks like. So now we can start to see that the combined information we have from human research is reasonably conclusive that applying stretch to limbs does not provide increased ranges of motion except for serial casting. So the overall conclusions we have so far is that stretch using splints, controlled torque or serial casts does not appear to result in lasting changes in range of motion, and that includes the following joints. The summary of this information is contained in a Cochrane review from 2017, and that's freely available online. There is, however, some hope that perhaps serial casting combined with other interventions may make a difference. So in this study, using serial casting combined with botulinum toxin and ongoing splinting and motor training for ankle contractures following traumatic brain injury. So this is 10 ankles with a control group receiving no intervention in terms of stretch. At the completion of the casting, there was a 26-degree difference between the groups. Week 2, a 26-degree difference between the groups. And at week 8, a 24-degree difference between the groups. So in this small study, there has been a demonstration that serial casting combined with other interventions may cause lasting differences in ankle range of motion. So a program of serial casting, botulinum toxin and motor training may be useful for establishing functional range of motion at the ankle. What can we do instead of stretching? Perhaps we need to apply opportunities for ongoing and early intervention after stroke. We certainly know that stroke survivors don't spend much time practicing the interventions that they need to practice. So how do we establish environments where people can begin to practice in the range of motion they need to be able to reach, pre-shape and grasp? And those interventions need to probably happen early. How much practice is required? We don't know as yet, but it's highly likely that it's many hundreds to thousands of repetitions for people to be able to regain their motor control, but also to maintain their range of motion. It's also likely that people after stroke and traumatic brain injury need to be followed up probably for the rest of their lives. How do we implement interventions that can provide support for people after their stroke or brain injury to continue to practice to establish range of motion and function as well? It's possible that this stretch may be one that could be considered for people that are able to get into this position. The research did suggest that perhaps this is effective in at least maintaining range of motion. And for those stroke survivors for whom they want to maintain their range of motion, perhaps this would be a stretch that they might like to try. So the take-home messages from this talk are, once again, a profound challenge for my own belief systems. That is, that we now have robust evidence that stretch interventions do not prevent contractures in humans. However, serial casting can lead to transient changes in range of motion. And serial casting, when combined with other interventions, may be of benefit, and this has been shown to be the case in the ankle joint. So that's the conclusion of this talk, and I hope you enjoy the rest of the MOOC. Thank you.